when we're injecting the cervical and thoracic spine, we wish to have the patient positioned with a pillow lengthwise down the body. This elevates the ribs, allows the head to be flexed in a position that eliminates much of the cervical lordosis and gives us easier access to the spinous processes in the cervical area. So again, we want the pillow lengthwise down the body as we have it here, not crosswise, so the patient can be relaxed. When we get down into the thoracic area, we can have the arms at the sides like this, or we can drop the arms off the table like this, and there's an advantage in that it slips the scapula sideways so that the border of his scapula is right here. Now I want you to put that arm back up, and that moves the border of his scapula over to here. And so there's some difference in how that moves the scapula off to the side. We know that when we enter the thoracic area then, the facets move medially and move into a line that's about a centimeter off the midline, or a finger breadth off the midline. And so when we have our spinous processes marked and our interspinous areas marked in the thoracic area, we then know that our next line of injections will be in the facet area. It's sometimes hard to differentiate exactly where the spinous process is and where the interspace is. And that's okay. You know that you're staying, as long as you stay in the midline, and we're just going to draw a line on down in the midline, being careful that we touch the spinous processes so we know that we're staying in the midline. Our next line, again, is about a finger breadth off the spinous processes, and this is the line of the facets in the thoracic area. Our next line of injections is the area of the transverse process rib junction, and that's right in that area, and I can actually feel that rib transverse process junction. It's about 2 finger breadths off the spinous process and in line with each rib as we come down. So we have a rib that comes out right here. Our next series of injections in this area involve the ribs. In the upper thoracic area, the ribs can be quite difficult to feel. They get buried in the trapezius, they get under the scapula, and so we want to identify the border of the scapula. And so we can see the spine of the scapula right here and just mark a line on it. We know that sometimes the supraspinatus above that is tender, and we can go right down in that supraspinatus area or on the spine. We come over and we want to identify the medial border of the scapula, which is right here. And this is again with his arm dropped off the side of the table, so the scapula is moved sideways. Medial border here. Sometimes that's tender, and we inject the area right along the medial border, and we'll show how to do that in a moment. And there's the bottom of the scapula right there. So we now have the scapula outlined, but we cannot see the top of the scapula or feel the top of the scapula. It's buried in the trapezius muscle. So we'll come back and approach that in a few moments. Now we're going to focus on the ribs. And when we want to inject the ribs, we want to find ribs down in the mid-thoracic area that are easy to feel. And as I said before, when you get up into the upper thoracic area, the 3rd, 4th, and 5th ribs, they can be quite difficult to feel under the trapezius. But down here at the 7th, 8th, 9th ribs, the ribs are fairly prominent. As we palpate these, we want to carefully palpate down the ribs right at the angle of the rib, where the rib turns in the chest wall. And I can feel his angle, it's right there. And this is an area where there's a lot of ligaments coming up and attaching from that lumbar area, transitioning with ligaments that go and the muscles up to the cranium. And so it's an important area to think about, that angle of the rib where the rib turns. It's a bump for a reason, and that reason is that there's a lot of ligaments there. It's a busy area. We want to identify then the ribs, and as I marked here, I can feel his rib coming across, and we know that the rib transverse process junction, as opposed to the facet line, is about 2 centimeters or 2 finger breadths off of the spinous process. We then identify another rib. There's a rib right there, coming across like this, and another rib right there. And you can see that when I do this technique, what I do is I place my fingers on either side of the rib. So I'm locking that rib between my fingers. So I have excellent feel for the rib with a lot of skin compression. You can see how there I'm on the skin level, there I'm pressing the skin down, and I really can lock that rib right between my fingers. So I've got an aiming point to come down onto that rib right at that spot, which is just medial to the angle of the rib. And I know that I have to get my injections nearly or in around this area, which is the rib transverse process junction. Again, a very, very busy area. You can feel another rib right there. And then I get up here, I can feel a rib there. And then I kind of lose the rib in this area, but it probably is right there. And then there will be another one there. So we start down in here where we can feel the ribs with our injections. We start out again at the angle of the rib where the rib makes that turn, and very frequently when you palpate with your finger or your thumb, again being careful just to use one finger, one thumb, not your whole hand in this area, but just one finger. You palpate right at that angle of the rib, and people will say, boy, that hurts. That's a very, very tender area. Our next injections are carried out on the facets, which, as we said, are 1 finger breadth off of the spinous processes. Our next important injection site, we've done the spinous processes and the interspinous areas. And again, to reiterate, we come into the spinous process, and then we can come back out with a needle, and without pulling the needle out of the skin slide down and go into the interspinous area in between the two. When we bring the needle out and let our skin go, we need to remember that that's where our injection was, even though the needle stick is up this high. So our next needle stick is going to be down a bit lower. Again, in the upper thoracic area, we're aiming caudally. When we get down into the mid to lower thoracic area, we can actually come straight in because there's quite a lot of overlap of those spinous processes. We're doing the interspinous ligament, the spinous process, again keeping our fingers locked on that midline and locked on the spinous process. You'll have a much higher success rate of hitting those spinous processes if you do a lot of skin compression, pushing the skin in, and locking your fingers on that spinous process and then coming in directly onto it perpendicularly. You can aim a little caudally if you wish to for safety in this area as well. We can come right down, and usually people are tender down to the kind of mid to upper lower thoracic area, and then there's a skip space between about T7, 8 down to T11, and then T12 becomes involved in that upper lumbar area. Our next injections then are onto the facets. The facets in the thoracic area move medially so that they're 1 finger breadth off the spinous processes, and they move quite a bit deeper than they are in the cervical area. So our angle of injection is with the syringe straight down and then angled medially toward the spine. So this is perpendicular, so we're angling the needle medially toward the spine, keeping our fingers on the spinous processes here so that we don't drift off into the lung, and keeping our needle again aimed from perpendicular medially. This allows the needle to penetrate down into the facet area and keeps the needle from drifting off into the lung. These injections should be fairly close together because we're hitting both the facet and the areas between the facet as we walk down here. We can do this in a couple of different ways. We can come in and do an injection, come totally out with the needle, move down a centimeter or so, do another injection, totally out with the needle, move down another centimeter, do another injection. Or we can do an injection here, then come out to the skin line, again not out of the skin but out of the fascia, redirect our needle 10 to 15 degrees and go back in and then come back out to the skin line, redirect our needle and go back in again. These can be fairly deep injections here, and so we need to not redirect our needle too far because the tip of the needle will drift quite a bit further if we do that. In other words, if this is the midline and we're doing our injection and then I tip the needle this far and starting here with the tip of the needle I move down like this, by the time it gets down 3 to 4 centimeters, the tip of the needle is quite a ways from our initial injection point, and we really want it to be closer rather than farther out. So the angle of the needle it needs to be not more than 15 degrees or so, so that the tip of the needle doesn't go too far down or up. When we're first starting these injections, I recommend doing individual injections, just pulling the needle clear out, and moving right on down, meticulously injecting this area. And of course, we've already palpated with our regional investigators, our thumb or forefinger, and moved right on down, individually finding the tender areas and focusing on those tender areas of injection. So our injections, want to start there, and we want to lock our fingers on the rib that we can feel, and then we come straight in. The injection is perpendicular, not with the needle bent one way or another, but rather straight in, perpendicular onto the rib, with a lot of rib compression, skin compression down. You can turn your head if you want. A lot of skin compression down, and coming straight in, we come in and hit the rib solidly and do our injection of 1/2 to 1 cc of our chosen solution. We then move our fingers medially, and I'm on the rib and I have it locked between my fingers, come back out and do another injection there. We move right on over, and I've got the rib locked between my fingers, come in and do another injection right on the rib there. And finally, we're now over at the point of the rib transverse process junction. We come in with our final injection right there. So it's about 4 injections across that area, following that rib across. We know that if we have a rib locked here, we can then move our fingers so that my middle finger lies where my first finger is now, and my first finger lies above the next rib. So I simply lift my fingers in that manner, and now I have that next rib locked between my fingers. You can see that it's a little bit lower than where I drew my line. And so that's why it's important to palpate these ribs and palpate all of your anatomy. If I were to come in where my line was without palpating again, I would be in the interspace between the ribs. So again, I come out to where I can really feel the rib at the angle of the rib, come back in with my injection in this spot. We move right on up, and again, following that same procedure, coming to the angle of the ribs where we can feel it, and walking across the rib, do 3 or 4 injections till we get to the rib transverse process junction and inject that area. And we can feel his ribs, but we lose the rib right in here. So we know by this technique of coming in directly onto the rib here and then moving our fingers into the same hole that this finger was in, we can then move up and be confident that we're going to hit another rib here. When we do this rib that we can feel the depth on and feel the rib with a skin compression down, going back in, we watch how deeply the needle goes. You get used to doing this, just kind of mentally marking how deep that is. And so once you've found that point, how deep the needle is, you don't want to exceed that depth with your next injection up here. Again, a lot of skin compression coming down to that depth. If I don't hit it at that same depth that I hit it here, then I'll come back out to the skin level and I'll move down a millimeter or two and go back into that level. If I don't hit it there, I'll come back up. There's my midline, come up a millimeter or two from midline and try it again. That way you're experimenting at that same safe depth where you know you've hit this rib and moving the syringe up and down. And ultimately then you'll find that rib and then you can follow your line across again to the midline of the costotransverse process. One can also rib skin slide in this area. So you can come in, and this is another injection technique, come into the rib right here, and then come back out to the skin level without coming out of the skin, and slide the skin over like this, go back in, re-inject when you hit the rib, slide the needle out, come on over, and go back in again to the same spot. And then you have to remember, though, that you've skin slid across. So I'm going to keep my needle right here to where we are, and I'm going to let the skin go, and we'll see how far over we were. So you can see that we started out here. We're now almost over to the rib transverse process junction using a skin sliding technique. When people are starting out with prolotherapy, I recommend just bringing your needle out, going back in and re-injecting, doing multiple sites. I think it's less confusing and easier to learn in that fashion. Our next consideration, we can come all the way up to the third rib, which will be right here. Our next consideration is going to be the scapula and the top border of the scapula and the posterior third of the clavicle here. We've already said that we can feel the medial border of the scapula, and we may choose to inject that, but we feel that it's fairly flat on the ribs now, so we can be more safe if we bring the scapula up a bit, and we do that by bringing the patient's arm up behind their back. And so we can bring that up, and then you can see how the border of the scapula has really come up into prominence. But the border is now different from where our line was because we've changed our anatomy, so that we now have to move medially, and in the same manner we lock our fingers on the border of the scapula and come right into that border. Now a much easier and safer injection because the scapula is lifted up off the lung. Sometimes we will choose, if the patient's tender, to inject right across the scapula, but more frequently the area of tenderness is along the border and along the spine of the scapula, which also has now shifted into this area. Now, in order to find that top of the scapula, we have to elevate the shoulder even more. So you can lift up on the shoulder by putting a pillow underneath it, or raising it, or have an assistant lift on it. And now we can feel that paper-thin upper border of the scapula, which is right between my fingers here. And so to inject that, then we lock that scapula border between our fingers like this, and don't come into it from a medial direction laterally, but rather come into it from a direction perpendicularly onto the blade of the scapula. And so we're coming directly in until we hit the scapula, and which is prominent now because we pushed it up out of the trapezius. I can feel the edge of it right there. And so we lock our fingers on that, come in this direction to hit the edge of it, and then walk over until we drop off the edge, because we want to be as close to that edge of the scapula as possible. Since the scapula is so thin here, if we aim in this direction out toward the lateral part of the body, we will not hit it because it's paper thin. So again, to reiterate, we have to hit the scapula, walk to the edge of the scapula, because the levator scapulae attaches right at that angle of the scapula, and it's an important area that's exquisitely tender in people with whiplash injuries. Our next consideration here in the patient in this position is the distal third of the clavicle. And the trapezius comes up and hooks on the back side of the clavicle, the distal third. Nothing hooks on top of the clavicle here until you get out to the AC joint, which is right there. And so we're concerned about the back side of the clavicle. There's the top of the clavicle where my thumb is. As I push this skin down like this, Then we can bring our needle in to the lateral third of the clavicle, but on the posterior side. So the direction of the needle is straight down like this, with the skin pushed backwards and the direction of the needle coming down like this on the back side of the clavicle. Not on top of the clavicle like this, but rather on the back side of the clavicle, just walking out along that distal third where the trapezius attaches to the distal third of the clavicle. When we get down into the lower thoracic area, as I mentioned, oftentimes there's an area of no pain in this middle area, and so we're not doing anything in here. And then we get down to the T12L1, and often that's an area of involvement that we'll wish to inject, and the 12th rib is often an area of involvement. And we can feel his 12th rib right here, and we do it in the same manner again that we've done the other ribs, where we lock our fingers on that rib. We can feel it right there. We lock our fingers on that rib. We may wish to mark that. Carefully palpate the tender areas along it, and usually it's a little bit laterally that we feel it, and then come in with our perpendicular injections directly onto that rib, walking down the rib, again with our fingers locked over the rib, a lot of skin compression, feeling that rib as we go. We may wish to move up to the 11th rib, but more frequently we'll find that this is the 12th rib, which angles down quite a bit there, that's involved with this discomfort down in this area. We then move down into the sternoclavicular joint. And the sternoclavicular joint can be easily palpated and is frequently tender in whiplash injuries because of seat belts. I see it in women who develop a large, extremely tender joint, probably an osteoarthritic process in that area. It's fused really with the first rib that's right directly under that clavicle as the clavicle comes out like this. And so we can lock our fingers on it. It's not necessary to get into the joint itself. We really want to inject all around the joint with our solution onto the first rib, then medially into the tender areas all around the joint. Again, if this is a meticulous injection, it works best. If you do happen to get into the joint, that's fine, but remember that the capsule surrounds that, and we're probably getting solution in the joint by coming into the capsular area around it. The omohyoid muscle attaches right here onto the clavicle, and sometimes that's exquisitely tender, and we can push the tissue down and come into that clavicle and the omohyoid right in there. The ribs, costochondritis, we can carefully palpate down the ribs and find the individual ribs and inject along the costochondral area. There's between the rib, there's the rib itself right there, and another rib there. So I find that when I do this, injecting this area very meticulously is important. To come along near the bottom of the rib as I can, sometimes right on the flat of the rib and the flat of the rib here. Sometimes the pain will extend out about halfway to the axilla, and we'll follow that rib out and inject right along it. Sometimes, though, it's right medially and over the sternum, surprisingly, where we inject meticulously all around the sternum, and then again come into this area right along the rib, trying to get on the top part of it. And I find that the more meticulous I am about small injections all around this area, the better results I get. The peppering concept again. This is usually in the upper ribs, but can extend down on into lower ribs for this costochondral area. And again, don't forget about the midline. That is often tender as well, injecting all over the sternum. We then have the area in the lower part of the rib cage, which is the cartilaginous area. It's springy because we bend and move that cartilage around. The ribs end back in here at the axillary line. And yet this is often an exquisitely tender area in people. It's kind of confluent. It flows together. Sometimes it's tender on the anterior part just under the rib cage as well. And so this is an area, again, to be very meticulous with our injections. Again, pushing your fingers down to cause skin compression, because there is a space between the cartilage here that you can slide into as well, and staying on that cartilage and then injecting meticulously all around the cartilage. This is a spongy feel to it rather than the hard bony feel that we feel in the other areas. It's kind of a spongy feeling or a rubbery feeling. But again, you can't mistake it for soft tissue because you're injecting those ribs. Sometimes people will have tenderness at the lateral part of the rib cage here, and we'll do that from the posterior approach, hitting the ribs along the posterior axillary line, but usually that area is not tender along the ribs. We come down into the thoracic area then with the same technique of locking our fingers on the spinous processes and coming either perpendicularly or a little caudally onto the spinous processes and then sliding between them and coming between them. Now we can see that the spinous process here is not very thick. It's a fairly thin process. There we can see how thin it is. So I think often our needle just drops down onto the area just to the side of the spinous processes, so we may wish to inject a little bit as we come out in that area. So our line coming down on the spinous processes and the interspinous area, again injecting more perpendicularly the further down we get, because we can see this overlap of the spinous processes, which makes it impossible to go into the cord in this area. Then our next layer of injections is a finger breadth off the spinous processes. You can see if my finger's up here, coming in with our needle angled medially toward the spines so that it doesn't drift out into the lung out here. And we're coming down and injecting on the laminal area here and onto the facet here. So if our injections are fairly close together, we're probably hitting lamina and facets in this area. Some people have said that they can correlate the facet with the space, but I think there's enough anatomical variance in this area that it's probably best to just do fairly close injections so that we're sure that we hit both the facets and that laminal area here. Our next injection is the ribs and the rib transverse process junction. And so we can see the rib transverse process junction here of the second rib and the first rib up here. We mentioned one of the approaches into the second rib and first rib coming posteriorly and upward to avoid the apex of the lung here. Coming posteriorly and upward, we'll hit that second rib in the trapezius, and we'll hit that first rib after we've come off the C7 tip of the transverse process, which you can see right there. So our pushing the trapezius backwards and coming into that tip of the transverse process right there, and then coming in with our needle in a posterior medial direction and hitting that tip of the transverse process. You can see that the scalene's partly attached there, and then coming with our needle directly off onto the first rib right here that lies just below that tip of the transverse process in that area. So we slide from the transverse process off onto the first rib, again with our needle aimed dorsally and caudally onto the first rib, and walk out that first rib. In the thoracic area, we mentioned that our injections are down onto the facets and the lamina in the thoracic area. Our next line of injections is 2 finger breadths off the spine at the rib transverse process junction right here. This is a very busy area, lots of ligaments in this area, lots of these small muscles in this area, and lots of muscles coming up from the lumbar area, interdigitating with muscles going right up to the skull. If we move on out, we can see the angle of the ribs right here. This bump is that angle, and as I mentioned, usually people are not tender out beyond that point, but they will be exquisitely tender right along that angle of the rib, and then medially from that over to that rib transverse process junction. So again, our needle is directed perpendicularly to the rib as we lock our fingers We lock our fingers directly on the rib, picking a rib down here. There's 3, 4, 5, and 6. And so picking the 6th rib where we can feel that bump coming directly into the bump of the rib, perpendicularly right down on it. And then we can walk our needle across the rib till we get to that rib transverse process junction. Alternatively, we mentioned that we can slide the needle across, doing a needle slide technique or a skin sliding technique, and slide the needle across as we go with our injections. And a final technique is, which will be demonstrated in one of our videos, is to come into the angle of the rib and then bend the needle as we're coming across, bend the needle in and slide the needle across the rib like this, injecting small amounts of solution as we go till we get to the rib transverse process junction, where we then inject that area. This is a technique that's an advanced technique, but I certainly would not recommend initially when we're doing prolotherapy. We notice that the ribs here, the muscles all attached to the posterior portion. You can see the roughness and where the ribs attach until we get up to the 2nd rib here, and then the muscles attach on top of the rib, which is why our injection has to come down from the top here rather than from the posterior portion down on the 3rd rib, 4th rib, 5th rib, and 6th rib. We look at our scapula, and again we see this paper-thin border here. That's the attachments of the levator scapulae. They come up and hook at the transverse processes in the cervical area, and that's why we have to get that area popped up from underneath the trapezius by putting the arm behind the back. And then, rather than coming down in this direction onto the scapula there, because it's very hard to hit, you're going to slide off one side or the other, we come in this direction, perpendicular to the bone, and then we walk to the edge of the bone, drop off, and then come back slightly and inject that levator scapulae right along that area of the edge of the scapula there. Injections can be carried out deep into the supraspinatus, right down here, right along the spine, and of course all over the scapula here. We mentioned the injections of the posterior clavicle, and we mentioned pushing the tissue down and coming in on the posterior clavicle to hit the trapezius. And as you can see, we get out into the area of the AC joint, even with this injection along the posterior clavicle. We do not inject down on the top of the clavicle because there's nothing there. It's pushing the tissue down and coming in posteriorly on the clavicle. In the front of the model, we're using the sternoclavicular joint, and we can see that it's kind of an angled joint, so to get in the joint we have to come in from this angle, but I don't think that's necessary. Most people who have pain in this have a large joint that's probably so inflamed that they don't have an easy access to it. So I think that by injecting all around it, we do a fine job. We then need to come in underneath and get this rib costochondral area here of the 1st rib, and then walking down the sternum and all along these costochondral areas, being careful to carefully pepper this area all around the costochondral junction like that. And people are tender again partway out that, and so we need to walk out as far as they're tender along that costochondral area. When we get down into the lower rib cage, as we mentioned, the chondral area gets larger, a rubbery feel to it, and we need to carefully do that and pepper that entire area everywhere it's tender. And I found that a real meticulous peppering of that does a much better job of that. We can also do the xiphoid if we wish, if that's tender as well.